Good evening, everyone, and thank you for joining us tonight for the webinar on Understanding Lung Function Test, part of St. George Hospital CPD series. My name is Lydia Koenig. I'm CPD Program Officer, and joining me tonight, two facilitators, Dr. Martina Gleason and Kylie Turner, CNC chronic kidney disease from St. George Hospital. This session, I would like to start by acknowledging the traditional custodian sovereign people of the land across which we work. I recognize their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. And I'd like to extend that respect to Aboriginal and Torres Strait Islander peoples joining us tonight. And now I would like to pass it on, as I said, to our facilitators, Dr. Martina Gleason and Kylie Turner. Thank you.
Thanks, Lydia. I'd just like to introduce tonight's speaker, Dr. Zheng. He's a staff specialist in respiratory and sleep medicine at St. George Hospital.
Thanks for the introduction and thanks for the invitation. Yes, I'm a respiratory and sleep physician based at St. George Public Hospital, but also a sleep physician at Woolcock. Tonight, I'll be talking about mainly spirometry, actually, and a little bit about lung function testing. So this is part of the GP education program through the St. George network to foster better communication and co-management of patients with chronic diseases. I have included a QR code for the specific health pathway to the spirometry in the bottom left corner. So in that context, we'll be focusing mainly on the use of spirometry in your clinical practice. So hopefully by the end of the talk, you'll appreciate the importance of identifying errors in spirometry and its interpretation. I'll also cover other aspects of lung function testing and highlight its utility in managing chronic respiratory conditions or aiding diagnosis. And finally, I'll present a few lung function cases at the end of the talk to address any queries about lung function reports. And I'll take this opportunity to acknowledge the people of the Eora Nation, who are the traditional custodians of the land on which the meeting is taking place, and pay my respects to the elders past and present. Okay, so I can't emphasize enough how important it is to check the quality of the data before jumping into the interpretation. So you wouldn't, interpret an ECG or chest X-ray if it wasn't done properly, and it's no different when it comes to spirometry and lung function testing. So resist the urge to go straight to the numbers, which I have done in the past as an advanced trainee. But take time to first assess the quality of the spirometry, and even in the lung function lab, where we have experienced scientists, we don't always get reportable results. So I imagine it'll be more so the case in the community. So I'll start off with a case, a 68-year-old female, 10-pack-year ex-smoking history with 6 to 12-month gradual onset of exertional breathlessness, background of hypertension, osteoporosis, insulin resistance, and a possible remote history of childhood asthma. BMI of 28, and this is their spirometry. So if you look at their, if you look purely based on numbers, it would sort of support a clinical suspicion of asthma, as there is a 300 ml difference between the pre and post bronchodilator FEV1, or 18% change post bronchodilator. However, if you examine the flow volume loop, you can see the shape that is vastly different between the grey or the pre-bronchodilator expiratory loop compared to the post and orange. So in this instance, the only reason there's a bronchodilator response is the pre-bronchodilator spirometry was performed suboptimally with poor effort, rather than actually indicating asthma. So just a quick reminder about the role of spirometry. Along with medical imaging, spirometry is the bread and butter of clinical investigations for pulmonary abnormalities and symptoms. In asthma, so asthma is a clinical diagnosis, but certain patterns on spirometry help support the diagnosis, such as variability or bronchodilator response. It's important we monitor their progress and treatment response regularly with spirometry, particularly in those who have severe disease or frequent exacerbations, or those who are asymptomatic when they have a physiological decline. In COPD, it's required to determine the obstruction as part of obtaining diagnosis, and it helps identify cases in those who are exposed, such as tobacco, occupational, or biofilms. Again, it's important to monitor their progress, as further lung function decline may prompt a referral for consideration of additional intervention. Other uses include diagnosis of symptoms such as breathlessness, cough, and wheeze. It may help determine diagnostic and therapeutic pathways and urgency. We use it for occupational screening and monitoring, or as part of a preoperative assessment in terms of determining surgical fitness or guide perioperative care. In terms of contraindications, so what are the risks of spirometry? They tend to relate to the effects of forced maneuver, so such as breathlessness, cough, incontinence, pain, and syncope. In some cases, they can induce bronchospasms, such as in brittle asthma. As you can see in this case, the blue line is actually pre-bronchodilator and the purple is post-bronchodilator. With repeated forced maneuvers, it triggered bronchospasm. And you've got a drop in the FEV1 and FVC with repeated measurements. Similarly, for contraindications, it is related to the forced maneuver and pressure changes. I divided it into different compartments, so cardiovascular, intracranial, sinus or middle ear, and thoracoabdominal. So this is all from the asthma handbook, or spirometry handbook from the National Asthma Council. We also tend to avoid doing spirometry in those with viral symptoms or if tuberculosis is suspected, such as cases with hemoptysis. In terms of mitigating infection, so it's important to remember pathogens can be transmitted through their mouthpieces, any valves, any tubing, or through either direct contact with the bodily fluids or droplet infection. This was reminded and highlighted during COVID-19. So on the right, methods to mitigate infection risk. So, obviously hand washing, cleaning the device as per the manufacturer's instruction, single-use mouthpieces, spacers, and the use of filters and appropriate PPE. Spirometry maneuver can trigger coughing. So coughing, the effects of coughing and droplet transmission can be reduced if you coach the patient to stay on the mouthpiece, so into the bacterial or viral filter, or if they can bring a surgical mask, if they're still willing to do so they can cough into it to have it nearby in proximity between maneuvers. And as discussed at the start of the talk, it's important we obtain a high-quality spirometry in order to have interpretable data. And this requires a trifecta of a capable patient, which isn't always the case, a motivated operator, and precise instrumentation with regular QC checks. Again, I've included this QR code, which links to the National Asthma Council, demonstrating proper spirometry steps and techniques in both open and closed systems for your reference, or to pass on to your nurse practitioner. So what are the potential repercussions of incorrect diagnosis? Excess inhaler prescription, the cost of incorrect treatments and misdiagnosis, which in turn may lead to harms of delayed diagnosis, so emergency visits, hospital admissions, and then being on the wrong treatment pathway in terms of missed opportunities for treatment and early intervention. In terms of spirometry faults, we divide it into operator-dependent and patient-dependent factors. So ideally, from an operator perspective, they should have adequate training and experience to coach patients into producing maximum effort, as well as identifying and correcting any patient errors. It is important that we regularly calibrate the equipment. So this is an example of a 3-liter syringe drum. So most societies recommend, or most guidelines recommend, a daily check using a 3-liter syringe at different flow rates. But I'm not sure if it's readily available in the community practice. Okay, I thought I'll showcase some spirometry results and for you to decide if you would accept or reject the finding. So the first case, a 72-year-old female with breathlessness, 30-pack year history of ex-smoking with arthralgia and chronic cough. This is their FEV1 and FVC. So FEV1, 1.5 litres or 66% are predicted. FVC, 3.2 litres or 95% are predicted. And this gives you a FEV1 to FVC ratio of 45%, i.e. obstructed. Is that enough information for you to consider starting inhaled steroids and long-acting bronchodilators in a patient with chronic cough? However, if you examine their flow volume loop and their volume time loop, you can notice that they've got a slow start. So it's not a sharp rise as we expect from a proper expiratory loop. And there's the cough in the expiratory loop, and as a result, you have an artificially low FEV1 and inaccurate FEV1. So you would reject this trial as an acceptable maneuver, and you would not interpret this based on the flow volume loop. Next case, 55-year-old male, 40-pack year smoker with productive cough. Again, obstructive ratio with reduced FEV1 of 45% of predicted. Is this, indicative of severe COPD in the context of their smoking history? Again, looking at the flow volume loop, you see there's hesitation, and as a result, artificially low FEV1. And, falsely positive diagnosis of, obstructive physiology. Next case, 22-year-old female, non-smoker, asymptomatic, workforce screening for Defence Force application. The FEV1 is 2.35 litres or 84% are predicted. FVC 2.6 litres or 72% are predicted. So giving a ratio of 90%, so normal. It appears to have restrictive physiology with reduced FVC. Would you suspend their ADF application, refer them for further chest imaging? Again, if you look at their flow volume loop, this time there's early termination or glottic closure, which is their glossus closing off during the maneuver and preventing a representative FVC. So reduced FVC estimation inappropriately, suggesting a restrictive physiology. And you can see from their volume time curve, they really didn't reach plateau, and they terminated even sort of before 2 seconds. And then next case, 68-year-old male, 35-pack year smoking history, limited exercise capacity. FEV1 of 1.5 litres, 44% are predicted. FVC of 2 litres, 45% are predicted, giving an FEV1 to FVC ratio of 75%. Again, does this suggest restrictive pathophysiology? And if you look at the flow volume loop, again, it's demonstrating early termination. So stopping at the 2-second mark and didn't really get a chance to blow out the full FVC. And if you give them the chance, you can see they blow out to 4 litres. Well, close to 4 litres, and it's more indicative of obstructive physiology. And then a 47-year-old female, cough, wheeze, query asthma. This is their pre-bronchodilator spirometry. Is this demonstrating variability? So FEV1, so the first reading, 1.8 over 3.8, 2.4 over 3 litres, 1.6 over 2.9 litres. Do you accept these results, and how would you report which FEV1 and which FVC would you use? As you can see, there's kind of sort of two acceptable maneuvers. There's hesitation or reduced suboptimal effort with the 1.6 over 2.9 litre blow. And then looking at their volume time curve, you can see there's no overlap and there's a lot of scatter. So doesn't reach repeatability criteria. You can probably accept the 3.8 litres in terms of the FVC and probably the FEV1 of 2.4 litres if you cannot produce better attempts. And then finally, a 59-year-old male, 37-pack-year smoker with a hoarse voice and noisy breathing. In this case, they're quite consistent, but don't reach the what we expect in terms of the peak value. In this case, this is both acceptable and repeatable. The reason for the plateauing might be related to their underlying symptoms, so suggesting an upper airway or main bronchus pathology, and which require further investigation. So to summarize, acceptability, they need a short hesitation time, a sharp rise to peak, as you can see in this flow volume curve, and have maximal effort based on operator observation. They need to breathe out until their lungs are empty, so plateauing off the time volume curve, or at least having a forced expiratory time of close to 15 seconds. And then no evidence of common faults. These are the common faults. Again, this is from the National Asthma Council, and you can have a look at the examples later. In terms of repeatability, so you need to have at least 2 acceptable blows with FEV1 and FVC in close proximity to each other, so within 150 mils. If you look at the examples on the right, on the left, 2 graphs, you have the volume time curve and the flow volume curve. You can see, although all the maneuvers are acceptable, so 3 acceptable maneuvers, did not pass the reproducibility or repeatability criteria. Whereas on the right, you have both 3 acceptable maneuvers with repeatability. You can see the overlap on the volume time curve. So if you have, sometimes you can't achieve acceptable results. However, they might meet criteria to have usable FEV1 or usable FVC. So if they show no hesitation and there was no evidence of errors or glottic closure or coughing within the first second, you have a usable FEV1. And if you meet the criteria for end of expiration, so that is the plateau effect, plateau appearance, and or duration, and there's no sort of glottic closure after the first second, or hesitation or leak or obstruction of the mouthpiece or extra breath taken, then the FVC may be representative. If you're able to achieve 3 blows, we take the largest FEV1 and the largest FVC and the largest peak flow. And then for the other indices, choose the blow with the largest sum, or for example, FEV1 to FVC ratio. Okay, so in the next session, we'll just talk about spirometry interpretation. Again, we'll start off with a case. So 45-year-old female, gradual onset of progressive wheeze and voice change, background of childhood asthma and current 30-pack-year smoking history. They have already trialed Ventolin and Pulmicort with poor response. Is this indicative of COPD? And you can see that there's no bronchodilator improvement with an obstructive ratio. So the pre-bronchodilator and post-bronchodilator FEV1 is around 61 to 62%. So more so than any other test, the interpretation of normality is dependent on entering the correct demographic data. So male gender or male sex has higher spirometry indices than females, other than the FEV1 to FVC ratio. The gender should be entered as the biological sex, which is, while more data is being collected on the impact of age at transition. Normal aging, as we know, results in decline in all spirometry indices, as well as the FEV1 to FVC ratio. This is important when we discuss reference ranges later in the talk. In terms of height, it's assessed without shoes, and in those who have significant kyphoscoliosis or are wheelchair bound, we can use their arm span as a surrogate for their height. We often include a weight, so that it doesn't affect the normative values, but may help with interpretation. Ethnicity, it's a controversial topic. In the past, we have reference ranges for different ethnicity. So Caucasians generally have higher normative values compared to Africans and Southeast Asians. However, we recognize that some of these normative values does not account for socioeconomic factors or disparities in terms of early life exposure and nutrition, which may impact on lung function. So potentially by correcting for ethnicity, we may underdiagnose certain groups who are already socially disadvantaged and prevent them from accessing treatment. So there is a push to use ethnicity neutral reference ranges. However, again, this is a controversial topic at this stage. I thought I'll give you an example of the importance of entering correct demographic values. So this is an example of a 49-year-old male spirometry result compared to his normative values. So this is the observed or measured value. So he has an FEV1 of 2.74 liters over 3.3 liters. So 49-year-old male, 170 centimeters. This is his percentage predictors. As you can see, this suggests a restrictive physiology, which require lung volumes to confirm, but having low Z scores for FEV1 and FVC, with a normal FEV1 to FVC ratio. Now, if you enter the person doing the test into the wrong gender, so same observed values, but the predicted values go down, and as a result, no longer in the restrictive range. So this would fall within the normal population range or the standard deviation. And then if you enter the age wrong, so 1957 instead of 1975, giving the age of 67, again, within normal range. And then hopefully this will get picked up, but if you enter the weight instead of the height, clearly supernormal values. So next step, so visual QA of the flow volume curves, again, to exclude any faults. And again, reminder, the three things: good and brisk start, free from cough and artifact, and sufficient duration. So suggest you examine the FET, which is the forced expiratory time. Make sure it's at least 6 seconds. Or looking at the volume time curve to see if there's a plateau effect. And then recognize any abnormal patterns. So these are examples. A is an example of a normal flow volume curve. B, indicative of mild to moderate obstruction with the scalloping of the expiratory loop. And then further scalloping, you can see in a severe obstruction. In D, you have variable extrathoracic obstruction. What that means is that the obstructive anatomical pathology occurs outside the chest, hence it's subjective to forces of inhalation. And hence, during inhalation, you have truncation of the inspiratory loop. This is apparent on any closed loop spirometry systems, which so may not be measurable in the handheld open spirometry devices. And then in E, you have fixed large central airway obstruction, where you have the truncation of the expiratory loop. And that might look familiar if you recall the case that we just presented at the start of this spirometry, interpretation. If you have a fixed large central airway obstruction, you get this appearance. You hopefully won't see that very often. And then for a unilateral bronchial obstruction, you have this appearance. For restrictive, you have the classical sort of witch's hat appearance in those with chest wall or parenchymal disorders. Whereas if it's a neuromuscular restriction, you have a more of a lower peak flow, a more softish expiratory loop. And then mixed disorder, you have a combination of a scooped appearance and reduced FVC. So going back to our original case, so a reminder, this is what her flow volume loop looked like. So this was a 45-year-old female with a smoking history who hasn't responded to bronchodilators and steroids with obstructive ratio, but their obstruction with a reduced peak flow is due to a bronchus and tracheal lesion. So she had a left main bronchus lesion and partial obstruction of the right, giving this plateau appearance plateau appearance on her flow volume curve. So in this case, it'll be an urgent rapid access referral for assessment, or hopefully a CT would have been done at that point for tissue sampling and potentially debulking of the lesion in the left main bronchus. So finally, the next step are the spirometry interpretation. So we start off looking at the FEV1 to FVC ratio. So in the past, well, even now, gold uses a 0.7 as the cutoff between obstructive less than 0.7 and normal above 0.7. However, currently we're moving towards a lower limit of normal, or so less than 5th centile is being obstructive. So if the FEV1 and FVC ratio is below the 5th centile, it goes down the obstructive pathway. If it's above 5th centile, it's either normal or restrictive, or possible restrictive pattern. So next step is looking at the FVC. Again, in the past, we used the 80% of predicted as cutoff, but now moved on to the lower limit of normal, or the 5th centile. So if the FEV1 and FVC ratio is normal, the FVC ratio is normal, being above the 5th centile, they have a normal spirometry. If the FVC is below the 5th centile and they have a normal FEV1 to FVC ratio, possible restriction. And if they have a obstructive ratio and the FVC, again, reduced, possible mixed disorder. So in both these instances, you need lung volumes to confirm. Next, we discussed severity previously based on FEV1, 30%, 50%, 60%, 70%. Now we again moved on to Z scores. And then looking at bronchodilator response, again, there has been a change. So in the past, 200 mils or 12% increase in FEV1 or FVC, now a 10% increase of the predicted value in FEV1 or FVC. So what's the rationale for the change? So the FEV1 FVC ratio, that recommended change has been in place, at least in the Respiratory Society guidelines for a while. The reason, as we discussed, there is a natural or age-related decline in the FEV1 to FVC ratio. So the lungs or the alveoli become more compliant. There's a loss of structure with aging, even without any significant, smoking or occupational exposure. If we keep the 0.7 ratio, such as in the GOLD guidelines, it results in a significant number of false positives in more elderly patients, so males aged over 40, females aged over 50, and false negatives in young patients. So overdiagnosis of COPD in asymptomatic elderly without relevant exposure, and underdiagnosis of airway abnormality in children. The rationale for using the 5th centile versus the 80% of predicted, so it was an overdiagnosis in shorter and older adults and underdiagnosis in taller and younger adults. In terms of bronchodilator response versus reversibility, in the past, I guess some sites still use the term reversibility. This is a qualitative term and implies normalization of airflow obstruction after bronchodilator. The preferred terminology is bronchodilator response, is that you don't always achieve normalization of airflow obstruction, and doesn't mean it's not significant. So it's a quantitative term, and at this stage, we're using a greater than 10% increase relative to predicted value. The calculation is actually easier. You just look at the percentage predicted before and the percentage predicted after, and then just directly do subtraction if there's, if the post-bronchodilator minus the pre-bronchodilator predicted values are greater than 10%, it's a significant change. So it's preferred over the previous recommendation. The rationale is it minimized the effect of age, sex, height, and the severity of obstruction. And it's supported better by epidemiological data in terms of the survival signal compared to the previous 200 mils and 12% absolute value change. This is a reminder that bronchodilator response supports asthma but does not equate to asthma. Bronchodilator response is also observed and almost at least as common in smoking-related COPD as those with asthma. Okay, so here's an example, 76-year-old male, retired stonemason, ex-35 pack year smoking history. So the first step, we, looking at flow volume loop looks good quality and scalloped, i.e. suggesting there's obstruction. The FVC, or the total volume, looks reduced, so about 1.5 litres. So you're thinking, is there going to be a mixed disorder? And we're looking at their spirometry values. So first step is their FEV1 to FVC ratio. So this is that value we use, at least in our lab. So this is 42%. So this is their pre-bronchodilator FEV1 to FVC. This is their lower limit of normal, and this is their predicted normal value, i.e. the 50th centile, based on the demographic data, the normative values that was entered. So in this case, it's 57% of predicted, a Z-score of negative 4.4. So this is consistent with obstruction. The next step, so is this pure obstruction, or could it be a mixed disorder? Looking at their FVC value. So again, the predicted value is 1.59 litres, sort of matching the flow volume loop. This is below their lower limit of normal, a Z-score of -3. So this is, so it's not above the 5th percentile. So both the FEV1 to FVC ratio is reduced, as well as the FVC, so that it's a possible mixed disorder. And as discussed, it doesn't mean it confirms concurrent restriction physiology. It could still be gas trapping, so you need lung volumes to confirm this. And then just to highlight that point, this patient went on to have lung volume measurement, and you can see their total lung capacity is actually normal at 92% of predicted. And the reason that FVC is reduced is because they have an enlarged RV. So just a reminder, FVC plus RV equals their TLC. So when they have gas trapping and an increased residual volume, their FVC is reduced, giving the appearance that there's possible restrictive physiology on the spirometry, but it's not the case. So obstruction with gas trapping or hyperinflation. And this is a nice segue into discussion of other components of lung function testing and their role. So in the spirometry, in the lung function lab, we have obviously other tests beyond spirometry, and I believe pre and post bronchodilator spirometry is the only thing that can be billed in the community on Medicare. We have the first three, which forms the traditional lung function test that you're all familiar with. The next three, we'll talk about FeNO and FOT a little bit later, but they are useful to characterize airway disease, so diagnosis, phenotyping, treatment response prediction, and disease control in asthma and COPD. The next two is more for neuromuscular patients, so we might do spirometry with them sitting down or lying down compared to them sitting up in terms of the traditional position, and seeing if there's evidence of diaphragmatic weakness, cough peak flow, because they might not be able to form good seals, and then respiratory muscle testing, which is diagnostic as well as prognostic, and treatment guidance in terms of need to consider NIV. The next three is more functional testing, so 6-minute walk distance and walk test, which you're all familiar with. We use it in COPD patients, IPF, and pulmonary hypertension patients. Again, good prognostication value and also useful for breathlessness assessment. Cardiopulmonary exercise testing, sort of the fallback option of all the other cardiopulmonary assessments are normal for breathlessness and may pick up early subtle pathophysiology and determine the rate limiting system. So is it, for fitness, is it cardiovascular, is it pulmonary vascular, is it sort of a neuromuscular pathology, or is it, psychological or supratentorial? High altitude simulation testing for those who have chronic lung disorder, who sort of borderline with it. You need to assess whether they need supplemental oxygen therapy before their overseas flight. And then shunt fraction, not very often done, but more for patients who have unexplained hypoxia, looking for right to left shunt. So I've put stars next to the ones that we do for breathlessness. Obviously not a shotgun approach where we do them all, but in an algorithmic or ordered approach, depending on their history examination and imaging findings. So lung volume utility, the previous case already highlighted in a way, but here are some examples or cases where lung volumes proved useful. So first case, 65-year-old with cough, dyspnea, smoking and occupational exposure with crackles and wheeze. This is the FEV1, FVC. You've got a scooped or scalloped loop. Is this a mixed disorder with a reduced FVC? And just like this previous case, the lung volume demonstrated a normal TLC, increased RV to TLC ratio, and reduced inspiratory capacity indicative of gas trapping. So it suggests pure obstruction rather than concurrent restriction. Another case, 32-year-old male with breathlessness and orthopnea, clear chest on examination and imaging, normal FEV1 to FVC ratio. Both the FEV1 and FVC are reduced and the flow volume looks submaximal. They go on to have a lung volume which showed reduced TLC, increased RV to TLC, so sort of suggesting a complex restriction, and in this case, suggest a neuromuscular weakness coupled with their history of orthopnea. Next case, 54, rheumatoid arthritis, new onset dyspnea and crackles on examination. Spirometry showed a normal ratio, but the actual indices are normal. However, if you do their lung volumes, their TLC is reduced, and they have reduced RV, more so than the TLC. So a reduced RV to TLC ratio, so early restriction that's not picked up on their spirometry. So the pattern of their volumes on their body plethysmography is useful. So it confirms restriction. So spirometry only suggests restriction. It doesn't confirm restrictive disorder. It identifies gas trapping and it's able to differentiate different restrictive patterns. We talked about neuromuscular versus fibrotic. It doesn't show versus chest wall disorder versus severe obesity. And it might help with to identify early pathology, such as the case we just mentioned before. Okay, next case, case 3. So 62-year-old female, background osteoporosis, ex-smoker, 10 to 15 pack year smoking history. They had very good baseline, exercise capacity, was previously walking 30 kilometers a day as a professional dog walker. They had gradual progressive exertional dyspnea over 5 years. The medications, so denosumab, vitamin D and caltrate for the osteoporosis. And they go on to have a spirometry. You have a reduced FEV1 to FVC ratio of 65%, normal FVC with evidence of bronchodilator response. Their CT chest showed no interstitial changes or emphysema, normal cardiac appearance, but increased pulmonary artery diameter. They were trialed on Briolipta, however, no symptomatic improvement. What next? So they go on to have a lung function test, and in this case, they had normal lung volumes. However, their diffusion results were abnormal. So reduced DLCO, 47% are predicted, and a reduced transfer coefficient, so reduced KCO, 45% of predicted. So the KCO is sort of indicative of the efficiency of the alveolar to capillary space or interaction or interface in terms of ability of gas being transferred across from the air onto the blood and, well, bound to the hemoglobin. She also had a significant exercise-associated desaturation, again supporting this, suggestive of a vascular, pulmonary vascular pathology. So diffusion capacity is a measure of efficiency of the lung. So the alveolar capillary interface is a gas transfer surface, and it needs to be interpreted in conjunction with their hemoglobin, as well as their lung volume. So low DLCO, such as the case we've seen before, could be due to anemia, pulmonary vascular abnormality, so such as pulmonary hypertension, PE, and vasculitis. So in this case, you have a normal single breath lung volume, but reduced transfer coefficient or KCO, or they have loss of alveolar and capillary structure, such as emphysema ILD, so reduced single breath volume, and reduced or normal KCO, or reduced lung expansion, such as a neuromuscular disorder, chest wall disorder, or previous lung resection or poor effort. In this case, we have a reduced single breath alveolar volume, but increased KCO, as the entire cardiac output is diverted or go through the normal capillary system. So back to our case 3, based on the reduced DLCO, went on to have further cardiac assessment, so transthoracic echocardiogram, suggesting features of pulmonary hypertension, which is confirmed on the right heart catheterization, evidence of pre-capillary pulmonary hypertension, referred to the pulmonary hypertension clinic, and commenced on pulmonary vasodilators. Hey, so final case. 31-year-old with chronic episodic cough and dyspnea, background of seasonal allergies, trialed on inhaled corticosteroids as needed, short-acting bronchodilators, but still recurrent presentations. They have trouble performing their spirometry. As you can see, this is a very poor expiratory loop, and their trials are all over the place. Is there a role for FeNO or FOT, or forced oscillometry technique, in terms of achieving or assisting the diagnosis and management guidance? So what is FeNO? So that's fraction of expired nitric oxide. So nitric oxide is a gas that's normally found in each exhaled breath in all humans, in very low values, so it's measured in parts per billion. In asthma patients, particularly in those with Th2 pathway inflammation or Th2 pathway induced asthma, they have increased levels of inducible nitrous oxide synthase, so iNOS. And this enzyme produces nitric oxide in the airway epithelium, which can be detected by a handheld analyzer. So this pathway is triggered by IL-4, IL-13, IL-5, and is associated with high eosinophil levels, and as well as atopic asthma. The handheld device, I guess in UK, it is funded by the NHS for GPs to perform, but currently the Medicare system does not fund any FeNO measurements in the community GP practice, unfortunately. FeNO can assist in the diagnosis of asthma, and an elevated FeNO in the presence of suggestive symptoms support the diagnosis of asthma, and indicates they're likely inhaled corticosteroid responsive. FeNO can also aid in treatment decisions in those who already have asthma or COPD asthma overlap, as it can highlight non-adherence or poor technique, or in terms of treatment decisions, whether to escalate the dose of ICS, or if it's low FeNO in a symptomatic patient, whether to consider a alternative diagnosis or investigate treat down a different pathway. It is also predictive of biological therapy. So a lot of our biologics, particularly the Dupi, the anti-IL-4 and IL-13 medication, being able to suppress FeNO is part of its positive outcome. FeNO can be used for prognostication, as seen in this table. So used with it, whether they've got clinical factors, their genostep, their eosinophil count, their fraction of expired nitric oxide can predict their risk of future severe asthma attack, and can be incorporated into treatment decisions or monitoring. It can also predict lung function decline and future poor asthma control or loss of control. So quite useful in the asthma population. It's not something that we do once. We do it, upon follow-up in patients that need to be closely monitored, particularly in our severe asthmas. But another tool, it's been around for a while, but only recently adopted into sort of lung function labs and respiratory practice, although it's been in the research field for a number of years. So it's a forced oscillation technique, employs a small amplitude pressure oscillations. So that's delivered sound waves through a loudspeaker, superimposed on normal, just tidal breathing. So different frequencies of sound waves at different, delivered at during normal tidal breathing, and then measurements of their respiratory system impedance. So the resistance, or airway resistance and reactance, or ability of the respiratory system to change. So it kind of indicates where and how much the lung may be obstructed. As you can see, it can be done in kids, and that is part of why it's an attractive alternative to patients who can't perform spirometry. So it's non-invasive, effort independent. So going back to our patient who had the spirometry-induced bronchospasm, so, you know, with repeated force maneuvers, what would be attractive. Can be used in bronchoprovocation testing. Again, we've discussed children, elderly, those with weakness or poor coordination. It's also more sensitive, so useful in asthma with preserved spirometry, you know, have suggested symptoms, but each time they come to the lung function lab or to your clinical practice, the spirometry is normal. And then peak flow, which is more of a large airway function, doesn't pick up any significant variability. It can predict future loss of control and predict early disease in those, such as in those with COPD. Okay, finally, how much time do we have left? Maybe 5-10 minutes. So understanding lung function test reports. So the goal of our reports to the audience, whether it's other specialties and GPs, is to describe 3 function properties of the lung. So the airflow, their lung volume and capacity, the gas transfer or diffusion. Hopefully it's clear, concise, and informative. However, we also do not want to overcall conditions. So the recent guidelines want to emphasize that lung function report describes a physiological change, a diagnosis in the right clinical context, but doesn't provide a pathological diagnosis alone. We need to take into account there's a degree of uncertainty in that, you know, that the day the patient comes, it may not be representative of their actual lung function testing, or actual lung function compared to the time of testing. You know, pre-test probability will be different from patient to patient, and the validity of the reference ranges, as we discussed before. In terms of lung function reports, what we describe is, you know, what the pattern is. So is it normal or supranormal, or is it impaired? And if it's impaired, is it obstructive, restrictive, or mixed? If it's restrictive, is it a compliance issue or a weakness issue? Additional clues from the lung volume, so is there evidence of gas trapping, hyperinflation, and obstruction, which might explain some of their breathlessness. Or in cases of restrictive physiology, is it simple or complex? So simple meaning a chest wall or interstitial lung disease, complex whether they've got concurrent small airways disease, such as, you know, sarcoid or hypersensitivity, or they've got concurrent, you know, asthma or COPD along with a restrictive disorder. You know, morbid obesity in those with, you know, class 3 and above obesity, we get to see changes in their lung volume. Because they have, you know, smaller closing volumes, you know, we get, you know, changes or increased changes to their airways obstruct earlier. Some of it might be related to fat deposition. Was it a weakness process? Gas transfer, so that's a diffusing capacity. The pattern of the impairment, is it a volume loss? Is it a loss of the capillary alveolar structure? Or is it a vascular or cardiac output abnormality? And then the indication of severity, which may correlate with their prognosis. as well as quality of life and function indications. So if you have a report back from us, when to refer, so I guess even if you get a normal pattern and you have unexplained breathlessness and you have, or at least the cardiology team have excluded cardiac causes, may consider referring back to the respiratory physician or to the St. George Hospital public sleep clinic. Oh, sorry, public respiratory clinic. Apologies. If they have an impaired pattern and if it's obstructive, consider whether they need further phenotyping. Do you need a pheno level to decide, what's happening with their inhaled corticosteroid? Do they need inhaled corticosteroid? Does that need to be titrated? Any restrictive pathology should, unless it's already an established known condition that's stable, you would consider, referral for us to work out, is this ILD where early intervention and diagnosis is important? Is it a chest wall disorder? Is it a neuromuscular process? And again, any features from the lung volumes, if they've got gas trapping, hyperinflation, COPD who's symptomatic, do they need to be considered for endobronchial valves, pulmonary rehab or modification of their inhaler therapy? And we've already discussed, simple complex restriction, completely different investigative and treatment pathways. Any gas transfer abnormalities, refer, particularly, reduced KCO, reduced DLCO, it needs to be highlighted. And then in terms of the severity, prioritize those with more impactful symptoms and more severe impairment. I thought I would just highlight some of the changes in 2021, 2022 standards from our society. So we already discussed that we use biological sex rather than gender, sort of incomplete understanding of race and ethnicity. And now we use GLI reference equations for all the spirometry lung volumes in DLCO. Defining normal range, and we discussed this, so lower limit of normal, 5th centile, rather than fixed ratio or fixed predicted values. Bronchodilator response, we've already discussed this, and then sort of the Z scores in terms of severity, although it's not all accepted and completely adopted into practice. I might show a few lung function reports. I'm happy to open up for questions if what do the people think and the crowd think?
There's no questions at the moment, Tom.
Okay, I can keep going.
Yeah.
So this is an example of a normal, always start off with a normal case. So normal spirometry. So everything, it's kind of easier once you've had, when you've got the Z score, everything's in green. So if we just go through the boxes, so FEV1, FVC ratio, the FVC is normal, but once you've got, body plasmography, you can just go straight to TLC. So not restrictive, not obstructive, and normal diffusing capacity. Forgot to mention again, bad habits, look at the flow volume loop first. Next case. So this is an example of a severe obstruction. You can see their FEV1 FVC ratio is 39% of predicted with significant bronchodilator response. So just to illustrate the maths, so their percentage predicted pre-bronchodilator is 18%, their post is 40%. So it's a 22% change. So that's more than 10%. That's a positive bronchodilator response in the new system. In the old system, we would go 1.06, take away 0.48. That's more than 200 mils. And then look at the percentage change. Well, I mean, this is pretty obvious, 122% change. So this is a positive bronchodilator response in both the previous and the current recommended interpretation strategies. And then looking at the lung volumes, again, normal TLC. So their reduced FVC is not due to a restrictive process. You have increased RV and increased RV to TLC, leading to decrease in their FVC. Their diffusing capacity, so the DLCO is reduced. And part of that is due to impaired gas mixing, so the VA is low compared to the TLC. And their FeNO is markedly, very elevated, suggesting, or hopefully they're on inhaled corticosteroid, either sort of poor technique, not enough dose, or not taking it, or something else is driving, is there another allergy that they're being exposed to at home? So this case, the flow volume loop looks, that witch's hat appearance. The FEV1 to FVC ratio is 78%, the Z-score 0.3, it's normal. They have reduced FEV1 to FVC, so suggesting restriction, which will confirm on their body plasmography. So their TLC is reduced, so that confirms restriction. Normal RV to TLC ratio, so simple restriction. So this case is a patient with progressive pulmonary fibrosis on nintedanib. Their diffusing capacity is reduced, so reduced DLCO in the setting of their pulmonary fibrosis, and you can see they've got significant exercise-associated desaturation on exertion with a mildly reduced 6-minute walk distance. This is a different restrictive physiology. So you have normal ratio, mildly reduced TLC. However, the FVC is markedly reduced because there is increased RV. So you wonder if it's gas trapping or impaired lung emptying. Looking at the flow volume loop, you don't see a lot of scalloping, so it's probably suggestive of a neuromuscular process, and you note there's a reduced peak flow. And the diffusing capacity is reduced, but with a normal, slightly elevated KCO, probably suggesting a neuromuscular process. I think this one was a diaphragmatic palsy. Okay, so take-home messages. So examine the flow volume loops. Interpreting poorly performed tests will impact on the treatment pathway and patient care. Utilize spirometry in your day-to-day clinical practice. Refer on if the spirometry cannot be performed, or like it's difficult to perform in a difficult patient, or if other lung function tests are required. And then, you cannot interpret spirometry and lung function tests in isolation. Incorporate with, clinical history, exam, and imaging. Any questions, feel free to email me or direct it to me, but I'll see any in the chat. And this is a contact for Lung Function Lab, and I'm sure most of you know Jay, our head scientist. And this is your local health pathway, and this is the asthma. This is the QR box to the spirometry testing interpretation in the health pathway. And I might just finish there.
I've got a question for you.
Yep.
And it says, would you please be able to elaborate on the role of spirometry in monitoring patients with known asthma? Guidelines suggest we should assess asthma control by symptoms. Should we be monitoring anything in particular on spirometry in known asthmatics to determine whether someone needs their medication to be up titrated?
Yep. So agree symptoms in terms of, well, there's a portion of patients where they may not notice, i.e. they're asymptomatic for lung function decline. So if it's a true representative spirometry where you have a baseline and a new value where there is a decline in the spirometry, that would be useful for consideration of either escalation of treatment or time to discuss with the patient if they're using the inhaler properly, if they're using the inhaler at all, or evaluating whether a dose escalation or another additional pathology or exposure need to be evaluated. I guess in patients with symptoms and the spirometry hasn't changed, you might want to consider, is there another diagnosis? Is there a different pathology that's being missed rather than keep escalating their inhaler therapy? Again, sometimes pheno would come into hand. In our practice, we would reevaluate the patient, particularly the severe, the people who don't have clear symptom change despite a lung function change. Those with frequent exacerbators, we would reevaluate their spirometry and potential pheno testing at each clinic appointment. But that's because we have the luxury of doing so as well. And I understand, in clinical practice and GP practice, you don't have all the investigations in front of you, and you have to, see the patient and make a clinical call rather than send them away and bring it back. Appreciate it's a different scenario.
And as a follow-up, the same questioner asks, is there a particular goal or target in terms of FEV1 to FVC ratio for known asthmatics? So in other words, what are we monitoring for?
Yep, good question. Again, it probably depends on their baseline, and depends, what age they start with and whether they've got other concurrent, whether they've got asthma, COPD, whether they've got fixed obstruction from years and years of exposure, potentially in some patients who were, elderly patients who did not have the luxury of having preventers or being on preventers when they're young. They might have asthma remodeling, even without any significant occupational or tobacco exposure. So it all goes back to what their baseline is when they're well. So hypothetically, you have a new patient, you have an abnormal spirometry, you treat them and assess if you can, ideally in asthmatic, normalize their spirometry, so normal ratio, normal FEV1, keeping in mind that what we discussed is we don't know what a normal, we don't know the relevant reference range or normal value is for that patient. We don't know their early exposure history, developmental history. So potentially, if their FEV1's a little bit down, or their FVC is a little bit down, or their ratio is a bit down, that might be normal without having previous values to compare with. If you do have a value where the patient is well, that would be your goal in future, but also appreciating with age, you have age-related decline in the FEV1 to FVC ratio, and you have age-related decline in FEV1. And I didn't bring it up, but it's controversial what counts as a significant change over time. 3-month versus a year, different patients, different ethnicity, different disease process, and we don't know.
Thank you for that. I have no more questions. So
thank you very much. Thank you, Dr. Zheng, for a very detailed presentation. Dr. Martina Gleason and Kylie, thank you for your facilitation, and thank you everyone for joining us for tonight's presentation. We look forward to seeing you on Tuesday, 19th of November, last in 2024, St. George webinar on emergency medicine. Please also fill out evaluation survey, and if you haven't already done so, please provide your feedback on a general practice CPD planning survey that went out today, and it is available in the chat box as well. Any questions or queries, please reach out to CPD team, and we're happy to assist. For now, thank you everyone, and good night.